and thank you so much for joining us today for the webinar, The Digital Implantation, Predictable Aesthetic and Functional Results, Easily and Securely. It is a great pleasure to introduce to you Dr. Jesper Hatt, whose aim during this presentation will be to focus on the do's and don'ts of aesthetic planning, the advantages of backward planning, the predictable implant insertion with surgical guides, and the aesthetic functional results with individual abutments. We'd like to thank Dr. Hatt for being with us today, and DT Study Club for making this lecture possible. Please take note of any questions and comments you have during the lecture, as they will be addressed by Dr. Hatt at the end of the presentation. Without any further delay, please help me welcome the expert himself, Dr. Jesper Hatt.
Well, hi and welcome to this presentation on the digital implantation. The things we're going to talk about today is how we do aesthetic and functional planning and execution of the planned implantation in a safe and easy way. So, just to outline what's going to happen today, we're talking about what we're going to do in regards of getting the perfect aesthetic planning, or at least the exquisite aesthetic planning, how we can utilize the plan and go backwards. So if we visualize our end result ahead of our implant treatment, we are able to get a better result functionally and aesthetically. And I'm going to show you how to do that. And in regard to that, I will show you how we use surgical guides in our implant, in our implant-based treatments to get a more predictable position of the implant in regards to our original plan. And as well, the last thing, we're going to cover the functional results with customized abutments. This is going to be a lecture about both the analog way, the old-fashioned way I'd call it, and the digital way that we're moving over to. Just to give you an idea where I'm sitting right now, I have my solo practice in Skagen. That's the most northern tip of Denmark. We have about 8,500 inhabitants in this region. And the reason I always point this out is because the things we're going to talk about today is actually possible to do anywhere in the world, in my opinion at least. So whatever kind of practice you have out there, this we're going to talk about today should be applicable to every practice, at least in my opinion. This is a view of the region that where I live. We have the west coast on the upper picture with the quite romantic city just to the ocean shore, and on the lower picture it's actually my son looking over the eastern coast. So it takes us about 20 minutes to walk from one coast to another. The reason I put these pictures up against each other is that it's actually also a way to look at the analog way and the digital way. And right now the oceans are both quite well, it's quite still, but sometimes it's getting a little bit stormy, and the oceans kind of clash together. So that's also happening in our transition from the analog to the digital world in dentistry, at least. So where to start? Usually I say it's not about tooth aesthetics. Tooth aesthetics is easy. If we want to really get a nice aesthetic result for the patient, we have to look at facial aesthetics. So facial aesthetics is mainly starting with the face, or at least I'd say as a minimum, always start at looking at the face. So here we have a patient, and I'm not going to show you the perfect cases today. I don't think they're that interesting. I'm going to show you some cases that will outline why we do different things today. So this patient I'm going to use just to show you how we plan our cases and why we do it the way we do. So first of all, we look at this patient and we take notice of the different facial characteristics. And when we look at the face here, it looks as if the eyes are in a different plane, the ears are different, the smile is kind of candid, and right now we don't know if it's because the head is tilted or if the camera was positioned in a different position. So according to Christian Coachman with his digital smile design, we start with aligning the picture. And the way we do this is we make a horizontal line. It's just a line that we put in there in a horizontal plane for us to look at. And then we align the picture to that. So we have the picture just right through the eyes, or the line through the eyes right now. And we make a correction of the picture. So that's adjusted like that. And then we take the first intraoral photo that we have taken. And usually when we do planning, we always start with photos of the patient. Sometimes we take some videos as well to get lip dynamics and to make an emotional connection with the patient, which I will get back to a little bit later. So we take our intraoral photo, we make an overlay of the existing photo, and then we copy the horizontal line and paste it into the position that fits our needs. This way we can just enlarge it like this, and we can start to make some measurements. I'm not going to go into details about how we measure this up. Christian Coachman does this a lot better with his digital smile design, and you can buy beautiful apps for your iPhone and for your computers on the internet. So these tools are really, really useful and helpful, and they are easy to apply in the practice. I don't have anything to do with these products. I'm just mentioning them because I really like to use them. It makes my life a little bit easier. So we make our measurements to find out where are the teeth in regards to the line, and then we can actually transfer this line to our stone model if we want to, or a digital model if we have done an intraoral scan, something like that. After doing that, we can start to plan where we want our teeth to be, because now looking at the teeth in this close, we kind of lose the ability to see where do the teeth, where we position the teeth in regards to the face. So here, because we know that the horizontal line is aligned with the face, we can start to plan the whole treatment from this. And here we're going to remove some soft tissue and add some length to some of the other teeth, ideally. Now we can transfer this to the stone model, as I said. We make an additive WAXUP, and we can present it to the patient. And we usually do this before anything else. We want the patient to have ownership of her own treatment. So we need an emotional acceptance. And usually what the patient buys is not actually one crown or a bridge or an implant treatment. It's the facial appearance and the function. So we want to get in line with the patient and get this emotional acceptance. So we show the patient how it's possible to look after the treatment, or at least outline it for her. And then when the treatment has been accepted, we can start to plan where we want to place our implant. So since we know where we're going to place the gingival margin, we know that we want 3 millimeters from the gingival margin to the top of our implant. And of course, that's because we always use bone level implants with some sort of platform switching to get a perfect soft tissue profile. I'll cover that in a moment. So here we plan the exact position of the implant. Now, in order to get this to work in real life, we transfer our additive WAXUP to a functional WAXUP. This way, we don't have to waste a lot of time before the patient has accepted treatment doing a lot of functional work. Now we're doing the functional work in the articulator. Of course, we have an idea of the functional work we have to do afterwards, but this is the time where we do the functional wax. And we can do this the old-fashioned way, the analog way, as we see here. We can do this in a combination with the archistigma, which tells us the exact movement of the jaw. Of course, we can transfer those data to a fully adjustable articulator and not just a semi-adjustable articulator as outlined here. Or we can transfer the data into a digital articulator. Of course, we need a phase bow transfer for the digital impression or the digital transferring of the data. So, but I'm not gonna cover that. There are a lot of companies trying to do this. KaVo has a wonderful way to do this, or at least something coming up in the near future. And I'm really looking forward to incorporate that into our practice as well. Of course, we can work with STL files. These are open files, and I really like to have open systems so you can switch to whatever system you like to work with and get the best system incorporated into your practice all the time, whether it's from one company or from the other. So when we have a plan in place, we start to make some considerations. Are we going to do some kind of immediate provisionalization, either direct or indirect? Or are we going to delay the pressure on the implants, the final restoration? Are we going to delay any kind of pressure to the implants? So if we do it directly with an immediate provisional, we do it the usual way. We take our provisional abutments, a bisacrylic material, and put it on top of that after putting the implants in place. Problem with this is actually the bisacrylic material that we have that all over the wound area, and it might compromise our implant healing. So another way of doing this could be by making an indirect provisional. So in order to do that, we have to know where the implant goes before we do the implantation. And the only way we can do that is actually by guided surgery. That way we would be able to get an indirect produced provisional that we could just screw into place as soon as the implant has been placed in the right position, angulation, and depth. Nice, easy, clean. It sounds a little bit more easy than it actually is, but it is doable. At the moment, I would say it's still needing some experience to do that, but it's doable. If we are going to load the implants delayed, we have the opportunity to use a flipper, a temporary prosthesis, removable prosthesis. We can use an Essex splint as the lower picture on the right, or we can use an appliance, a bite appliance like the splint on the upper right, if there's any functional issue that we're worried about before we put in the implants. Or of course we can make a Maryland bridge that doesn't take up as much space. I really don't use Maryland bridges that much because I think it's a mess to take them off and put them on during surgery. All the blood, the healing might be compromised because of the composite components. So usually I try to avoid it, but we still use it sometimes. So why guided surgery? Well, as I mentioned to you, the only way I see that we can plan an exact position of the implant is by using guided surgery. And it gets really easy to understand this as soon as you talk about indirectly produced temporary crowns on a temporary abutment, because you have to make these ahead of time. And the only way we can do this ahead of time is by knowing exactly where we're going to put our implant. So here we have the option to plan the implant position in really exactly in regards to the final prosthetic work that we're going to do. And the lower pictures are actually some pictures where we have either planned something immediately or where we have some kind of outline in place in the mouth during the X-ray picture, or at least at the time of the X-ray picture was taken, to guide us. Today we do a digital plan, digital WAXUP, and plan from that. So you can see we have all the different angulations in regards to our 3D picture. And again, it's really important for me to say again that I like these systems, and I really like it when they're open systems. This plan was done with IntoGuide, which is again an open system, an open software system for viewing co-beam images. And the IntoGuide software is actually just a plugin to the software that's actually a viewer by the company that makes this. What's it called? I get it. On-demand 3D, on-demand 3D viewer. So here we have the WAXUP on the left. We have planned how we want to put in an implant of a certain dimension. I think this was a Straumann implant, bone level implant. And as you can see, we were able to quite precisely place the position of the implant right there. The color of the sleeve, I'll get back to that. So our considerations in regards to our aesthetic plan here is using a bone level implant, could be any kind. We want a platform switch because we know that's a requirement if we want a stable soft tissue afterwards and a stable emergence profile. When we have these, we know exactly where we want the implant to be in regards to the bone. We can plan that in our IntoGuide software or in our co-beam software. When we know where the implant goes in regards to the bone, we just have to measure out how far is the distance from the bone to the soft tissue level that we're going to use. And this is where our pictures that we saw in a moment come in handy with our WAXUP. Because now we just have to measure out the most apical point of the tooth. Where is that in regards to our implant? And there has to be 3 millimeters. When we know this, we can start to measure out, well, how far is it from the implant to some point of marker on the transfer. And the reason we do this is because at the moment, as far as I know, there's only one company that lets you guide the implant to a certain depth. We like to use different types of implant, and that's why we always measure out how far is it from the bone level where we want to place the implant to the to a certain marker on the implant. And this way we know exactly where we're going to go during the implantation on the patient. So we can transfer this to our actual guide. I hope this is understandable. But there's a video that will show you a little bit about how we do this. So some of the challenges is that we have all these implant brands on the market, and all of them have their own software to do guided surgery. And it's kind of like whatever system you used to use, if you buy the software to that from that company, you're kind of like married to that because the software is quite expensive. And frankly, I don't like that. I'd like a system that is more open. So as I told you before, the on-demand 3D software has this IntoGuide app, which I like. I haven't seen anything else on the market that lets you get this flexibility. So as you can see here on the screenshot, we have the option to choose whatever kind of implant we want to use. we have the option to use, let's say, a cone lock, a screw line guide, or a cone lock implant. The cone lock has the platform switching, and cam lock gives you the ability to guide the implant all the way, also to the correct depth. There is also some drawbacks about the cone lock implantation, and I'll show that in a minute. Nobel Biocare, all the implants, whatever you like, and you can just pick and choose whatever you want to utilize. And there is more than 200 different implant brands here. All of the biggest implant brands are in the system, so you can use whatever implant you usually use. And after picking out whatever implant you want to use, then you can choose the drill kit that you use. And as you can see here, we have all the different drill kits available, which usually comes with whatever other 3D guided system that you use. A nice thing about this is actually if you let's say you take a cam lock implant and you want to place it, you can either choose to use the InterGuide universal drill kit to use it, or to place the implant. By doing that, you have one drill kit that can place any kind of implant in the world. The only thing you need is actually the implant driver to transfer the implant from outside the mouth into the correct position. And of course, you need the prosthetic tools afterwards. But for the surgery, you just need the InterGuide universal kit and the implant driver. And here you see the level of the sleeves that are placed in the surgical guide. And as you can see on the tooth number 44, it goes a little bit into the soft tissue. Now, with as little soft tissue as this, it's possible to fill a little bit around with the soft tissue. You can use a laser, cut away a little bit, or you could just press the guide into position if you want. But you have to have a little bit of experience to find out if this is possible or not. But the interesting thing here is that if you, let's say you choose a cam lock implant and you want to use your cam lock drill kit, well, you get these drill guides with you. And here you see the big difference between the different systems, because by using this, these sleeves that are matching the cam lock system, the sleeves get a little bit closer to the implant surface. This gives you a little bit more room for your burrs during surgery, but it also gives you the problem to get enough space for the sleeves. So this narrows down the usability of the guides. So I like the flexibility of using different guide systems. So here it's okay, but on the other hand, it's not that nice. And here we have the Nobel Guide system. It's a little bit closer still as the InterGuide system, but still you see the problems with tooth number 44. And here's the Straumann system. It gives you the largest amount of space, but also requires a lot of space around the guide, and it gets really, really close to the implant, so it makes it hard to get the right implant position in regards to the sleeves. So you have to consider this when you get your software for the guided surgery. And this was the universal drill kit that I was talking about. It has a lot of different drills in it, and you have these purple, yellow, and blue markings in around the drills. Those are the different heights or length of the drills, and on the actual surgical guide, every sleeve has the same color as in your universal kit. So it's really almost impossible to do anything wrong here, because you're always guided to what to do according to your own plan. And I like that. So here we have a video showing a quite large case. This is a heavily sedated patient. She had a really heavy gagging reflexes, and which is why we sedated her that way. We're placing our guide for the stabilization pins here, and she bites down into this guide at all times, just to make sure that this is the right position. Of course, before we did this surgery, we did all our planning, as you saw before, and we scanned the patient and we scanned the scan prosthesis, and we made some corrections just to make it possible to put in this this guide. You'll see that in a moment. It looks a little bit different than usually, but it's nothing more than a regular guide. We take out the pins after putting them in, stabilizing the guide, and if the patient, does she feel anything? She didn't. And here you see our upcoming guide with the different colors of the sleeves. And I'm going to show you how this guides our positioning of the stabilization pins here. So they go into the bone and stabilize the surgical guide, as you can see here. So the next point we're going to here is actually we wanted to do this almost a closed procedure, flapless. So we do tissue punching, where we just punch out the amount of tissue that's required to get our implant into the right position. Remove the guide after doing the tissue punch, and then we just remove the tissue, the soft tissue. And this is usually the part that takes the most time. This goes quite easy. Get the guide into position again. And the stabilization pins makes it pretty easy to put it into the exact position that we plan all the time. Of course, you have to take into consideration that there is the ability that there will be a little bit of distortion of the guide. That's actually where you really want to be sure that the guide is in the perfect position. That's actually just before you put in the stabilization pins. Because now everything depends on your planning and your positioning of the actual guide. We have this pre-drill just to make an indentation in the bone before we take our first drill. This is a grafted area, which you can see it's pretty hard to get the burr to the correct depth. But you go all the way until the burr doesn't go any further. You can see in my left hand I'm holding a key, drill key, which goes into the guide. There you see it. And it has a diameter that is the exact same outer diameter as in the guide, and the inner diameter is the exact same as the drill. So we step up slowly. We go up to the size we want, and here we're placing some direct implants, some interactive implants, and they are tapered. So we're doing a little bit of a trick in a moment, I think. Here we have the last burr. We only go to just into the bone, just to make sure that we don't expand the bone or the hole too much. And then we put on our implant. Yes, and we do it through our guide. This is a little bit tricky here because actually we put in all our implants through the guide at the same time. That stabilizes the guide as well. But you have to know that you'll be able to take off your guide afterwards. So here we have our implants in position. We take our well, these implants, the direct implants, come with a final abutment, stuck abutment on them, which actually is the driver. We change those most often to these temporary abutments. We had a shell provisional that we had made in advance, and we fill it up with a physical material. We have actually made sure that it fit our positioning of the temporary abutments in ahead of time, and just filled our screw holes with wax so it was easy to remove them again. And of course the screw holes in the temporary abutments was filled with Teflon tape. Teflon tape is really a fantastic material in these cases. It's easy to remove. It's much easier than these pellets that we used in the old days. So this way it goes a lot easier. So we unscrew it all, and because we had our plan, it goes off pretty easily. And now it goes to the lab where we, our in-house lab. It's just a regular small lab, because now we have to make sure that everything is adjusted. There has to be some composite that is being put up around the temporary abutments, and to shape the soft tissue the way we want it, and make sure that everything is easy to clean and keep for the patient. And then it goes back into the patient's mouth for the next 4 to 6 months. We test the occlusion, the function, everything, and we follow the patient the first week afterwards, 2 weeks afterwards, 4 weeks post-operatively, and then every month we take her in for a control just to make sure everything's going in accordance to the plan. So an example of our implantation with the guided surgery. This was a patient that was referred to us for implantation of 2 premolars in the lower jaw. And here we have a possible problem with the soft tissue. We were able to do a flapless procedure, but we considered doing a flap procedure because of the bone and because of the soft tissue. As you can see, there's not that much space for a punching procedure. So that's another reason why we really like our photos. It gives us the opportunity to take a look at the soft tissue in regards to our surgical plan. Applying our implant position, put on the implants, take our impression, and usually we do it with the open tray technique. In this case, we fixed them to each other with some composite material. Made our impression, and we get everything ready for our lab. Pictures on the USB disk, models, impressions, pipe records, protrusive pipe records for a individualized condylar angulation, and in this case a registration for the panel end articulator. Usually we use a KaVo articulator, but we wanted to try this panel end dentofacial analyzer by John Coyce, if it would work in this regard. So that's one of the areas that we're testing at the moment. So when the technician receives our work, he has to do some kind of consideration. This is an immediate provisionalization by us, but still we need to think about the emergence profile. And we need to think about it from the beginning of the case. As I told you, we know where we're going, and we want to plan every step backwards to get to that goal. And that's what I like about backwards planning. So we have visualized the final result, and here we are with our implants in position, and we have to do some kind of provisionalization. Oh, sorry. So we made a provisional. This is, I think it's 2 months post-operatively. You see a nice soft tissue healing. There's enough space for the soft tissue to heal and to swell and to shrink again, and it's in a way that it doesn't get inflamed. And here we have the trying of the final prosthesis. And as you can see, the technician here is able to kind of like pressure the soft tissue into position. Is the soft tissue perfect? No, it's not. and at the moment we did this was before we knew anything about how we could, well, manage the soft tissue approximately. About the abutments that we utilize. I like the stock abutments before. I thought, well, it worked wonderfully, but I also thought there were some problems. This is a customized stock abutment of the Straumann implant, and you can see the amount of soft tissue around it, and that worries me a little bit. Because how are you going to get all the cement away from that area? The soft tissue is being pressed into position. Beautiful about the technician, by the work he did. See it intraorally. We see the amount of soft tissue all around the standard implant. And here the crown is in place, and it looks beautiful, and it manages the soft tissue, as you can see before. It kind of like pushes the soft tissue into the correct position. And if we take an X-ray of this, it looks nice. You can see how the emergence profile is shaped by the crown, the implant crown. It's a cemented crown. We don't see any cement here. It looks beautiful on X-ray, but I can't happen to let the thought go that what about the cement we can't see on the X-ray? The X-ray is only a two-dimensional picture, and the only place we can see on the X-ray in regards to the excess cement is actually the area that we point to with our arrows. What about these areas? We're unable to see that on our X-ray, and we certainly can't see it in our cone beam scanner. It's totally impossible to see any cement there. So I really don't like the thought that there might be some kind of cement trap there, and I'm sure that if I cement enough crowns on stock abutments, I will see this problem at some point. So we came up with the thought, well, maybe we could do some kind of horizontal screws. This way we would have a retrievable solution, and we would avoid the problems in regards to fractures of the porcelain where we have the screw hole, the access hole. And it works okay. We have these stock abutments, and we can screw in our crowns, and 3 months later looks okay. Still not perfect, but it looks okay. But if you take a look at the tooth number 2-1, it's kind of like inflamed around the crown. As you might, I'm just going a few pictures back here. You might recall, if you take a look at the abutment here, it's as if it's really not that nice. I really don't like the margin here. And I wonder, here it doesn't look that inflamed, but it starts to look inflamed here. Could that be because there's some kind of margin that isn't sealed off? I don't know, but I can't let the thought go. So I thought we had to come up with another thing. And then we started to look at the possibility of using these zirconia buttons. I don't ever use zirconia buttons that are completely in zirconia, because I really fear that they're going to break because of the brittleness of the porcelain. So these are titanium abutments that go into the implant, and on top of that we have these customized zirconia buttons that are glued onto the titanium. The one thing that still a little bit of worries me a little bit is that I know that it's the glue that keeps those parts together. So instead of having 3 parts, the implant, the abutment, and the crown, now we have 4 parts that potentially could break somewhere in the future, since we have this extra or cemented, glued stuff in between. But so far it works really, really nice. This was the case we did 5 years ago, I think. And here you see the ability of the technician to place the margin. As you can see, we also used pellets at that point instead of rest tape, Teflon tape. Today we would use Teflon tape instead, definitely, because it's so difficult to get out these pellets, and they tend to get moist and all of that. So here we have the zirconia. We can place the margin perfectly where we want it to. And in the beginning, we placed, my technician and I, we wanted to place the proximal margin a little bit subgingivally, as if we had prepped the tooth, because that way we could work the same way we did with a tooth, and we could kind of like squeeze the papilla into the right position. Today we shape the customize the abutments a little bit different, so it's the abutment that squeezes the soft tissue instead of the crown. We get this beautiful result, and as you can see, we're able to squeeze the soft tissue into a nice position. This is at the point of a provisional cementation, I think, or well, I use a long-term provisional composite-based implant crown cement. So I really like the emergence profile of these products, of these customized abutments. On the posterior, we usually use titanium abutments, but I like the strength of the titanium inside the implant, and the soft tissue friendliness of the zirconia, the white color of the zirconia, so we don't get the shine through the soft tissue of the grayness that we sometimes see with the titanium abutments. So this way we get a nice aesthetic result, and we get a hemidesmosome attachment of the soft tissue to the zirconia, which I also happen to like. Usually when we see problems in regards to periimplantitis, when we take a look at and the hygiene is good, when we take a look at the function, that's usually where we have the problem. Usually we have some kind of parafunction on the crown, and that's why we lose bone around the implant. So always check for parafunction on peri-implant patients. Then we thought, well, why not take this a step further? Here we had a lady, a woman who came home from a party. She lived on the second floor in a house, and she had forgotten her keys, so she thought, well, maybe she could crawl up the wall and sneak inside a window that was open. She came to the window, and then she fell to the ground with the head first, and as you can see, she had multiple fractures of her teeth, especially in her maxilla. There was a complete blowout of her molars in her right upper side. You can see the huge defect distal to the premolars, as well as you can see the fracture of the palatinal cusps of the premolars on that side. A little more looking in the left side, where there was still some bone on the facial side. She got a condylar fracture in the left side of the mandible, and a couple of fractures of the lower teeth. So here it was a collaboration between our office and some maxillofacial surgeons in the hospital. The maxillofacial surgeons grafted the area distal to the premolars in the right side of the jaw and placed the implants there, while we placed the other implants. I don't know. Today we might be able to do a little bit better grafting than this, but this was the position that we got the implants in from the hospital, and we had placed our implant number, 1-4. Took our impression, and our technician made us these titanium zirconia abutments. They still hold up. I really like the soft tissue, how it looks around the crowns. It was really easy to remove the cement. I could see the if I just pushed a little bit to the soft tissue, I was able to see the junction between the crown and the zirconia abutment all the way around the crown. And that way I could really be sure that I removed everything. My technician, I think he did a wonderful job in consideration to how difficult the implants were placed. Cost is a little bit of a compromise here, but it's working. The space between the molars is because of the soft tissue on the model displaces the most posterior crown a little bit. And as you can see, the final case here in the mouth of the patient. So I think the technician did a really great job. And so far, as I said, it holds up. It's really fine. It's been in the mouth for about 5 years. 4 or 5 years. So far it's nice. We actually considered doing some ortho on her anteriors, but we didn't dare to do that because of the trauma. So that's why they stay like they do. So, in summary, we've been looking at the importance of photos to do our planning ahead of time, ahead of insertion of the implants is really important if we want to make some kind of facial aesthetic result. You can use video for lip dynamics and to get an emotional connection with the patient. We always start with the face. We use the digital smile design. We do a WAXUP in regards to the digital smile design we do. We can do that either in our hands or we can do it digitally. We're going to try to use the lithos scanner from KaVo, which has come to the market. Use it with the AESTETHIC to get the functional occlusion and make a WAXUP from our digital smile design. I'm really looking forward to that. Or we can transfer our manual constructed WAXUP, scan that, and put it on top of our scanned intraoral scan of the patient. So we have the ability to switch around the different data we have from analog to digital. We can have a digital model and just mill out a provisional or something that we can put on top of the teeth for the patient to see ahead of time. And as I said, I really like to analyze the functional occlusion with the AESTETHIC because we don't just get an idea about the jaw movements of the patient, we get the exact measurement of the jaw movements. We utilize IntoGuide in our surgical planning for guided surgery. The guided surgery is dictated by WAXUP, which is dictated by facial structures of the patient. Then we consider the right provisional for the individual patient. Is it going to be in direct or indirect, immediate loading or delayed loading of the patient of the implants? How do we want the soft tissue to look in the end? Can we use something that is removable to shape the soft tissue? Do we have to place something on the implant to shape the soft tissue? I really haven't talked that much about test driving the provisionals, but I really think it's essential to test drive anything we put into the mouth that's expected to last at least 10 to 20 years. If we want something to last that long, we have to test it. So I usually tell my patients when we put in the provisional, if anything breaks in the provisional, it's great. It's really great. It's just composite. It's plastic. We can fix it. And it gives us an idea that something we're looking for functionally. We haven't been able to see that in our practice, but when the patient gets home, the patient does whatever the patient does with her or his jaw movements. They function like they do usually, and they break something. It tells us something. Then we can correct it in provisional, test it again, and as soon as the patient doesn't break anything, we know here we have the option to do something that will last a really, really long time. Does it take longer? Yes. Is it more difficult to work with? Not really, but it takes a lot more time. That makes the treatment, the final treatment, a little bit more expensive for the patient. But I get to sleep a lot more relaxed every night because I know that my provisionals have held up and there are no problems in the provisionals. I would much rather have an idea where we're going and see the failures on the provisional than on the final result. And of course, we use the provisionals to shape the soft tissue to get a perfect emergent profile, or at least as perfect as it's possible to get. And to support it all, we use customized abutments, cemented, screw retained, occlusal screws, horizontal screws. Well, depends on where in the mouth, on what patient. Right now, I won't say we're going to do that forever, but at the moment we're using screw retained implant supported crowns on the molars, and we cement everything else on customized abutments on every patient. I rarely use any kind of stock abutment. When I use them, it's only for provisionals use. Yeah. And so we have come to the end of the presentation. I think I'm 2 minutes behind schedule. Again, a picture from the local area. We have the old lighthouse in the front where you put the coal into the basket and hoist it up when it's on fire. As the land further south erodes and puts a lot more of beach and land to the shore here, we had, after about 100 years, we had the need for another lighthouse. That's the gray lighthouse you see in the distance. And it was electrified. So we have an electrified lighthouse. And I like the picture because it's kind of like where we are today. We have the old analog way we're looking at right now, or traditional ways to do our implant treatments. And we're looking at this digital world coming towards us. And if we move further, it might look like a big lighthouse, but it's really nothing different than a lighthouse. I mean, it's nothing different than, it just looks a little bit different. It feels a little bit different when we work with it. But I think it gets us a better result, gets us probably a cheaper result in time, not at the moment, but in time it will give us a cheaper result. But definitely better aesthetics, better function for the patient. So with this, I have to thank you for the attention. And I can see that we have a few questions. Ali, he asks the name of the implant software on the screen. It's IntoGuide. By On Demand. I know that KaVo uses this along with Scanora, Gendex, whatever brand under the KaVo Kirk group that is used to take the images. You can get this software. And it's an open platform. It's an open solution with which works with the DICOM files, which can be incorporated into STL files. So you have the option to have your DICOM files from your cone beam scans and merge it with STL files. You can also just take your cone beam scan of the patient, have a WAXUP of one tooth, or you can take an impression of the patient, make a stone model, scan it in your cone beam scanner, and dot them on each other that way. You can make a lab scan of your impression or of your model and double it into your DICOM files. Or you can make an intraoral scan. It's right now there's a little bit of a fight between two companies about the technique, but it should in a short time it should be possible to do an intraoral scan as well and merge it into the DICOM files of the on-demand into Guide software. But it's on demand. That makes the viewing software, and it's into Guide. That's the plugin that we utilize. So, what are your recommendations for placing an implant on number 30 site with a patient who has severe bruxism and clincher? Recommendations prior to and after implant placement. Well, that's some of a question. First up, I would look at the total occlusion, complete occlusion on the patient. Number 30, that's a little bit tricky. I don't know if number 31 is there as well, but if it is, that would give you some kind of protection. But all of my patients that are parafunctional patients, they leave the office with some kind of appliance. I usually tell them if they use some kind of night appliance that will lower the risk with about 50% of fractures of the implant, fractures of the abutment or the crowns. They all use some kind of appliance. Of course, there are patients that don't want to use them, and I tell them that usually after 5 years we will see some kind of problem. Usually it's just a little bit of a porcelain fracture, but I don't know how to protect them anyway. We control our patients every month, but on the bruxism, I would definitely look at the functional occlusion, and I would refer you to look at the Pankey Institute, Dawson Academy, a little bit about John Coy's is also a good place, and Frank's Beer, of course. Those are the 4 places I would go to look more into depth about functional occlusion. They will definitely help you get some guidelines to what to do to protect your prosthetic work. I mean, whether it's implants or it's fixed teeth, the kind of thinking that you're doing is somewhat the same. I won't say it's exactly the same, but it's somewhat the same. You have to look at how you protect the posterior teeth of that force that these patients can put into it. And if it's some kind of parafunctional where you can't stop the patient from wear the teeth. So we're more in a position where we have to look at how can we protect the teeth instead of making up our work so stable that they won't damage it. Because I mean, whatever the muscles fight, the muscles win. We can put full zirconia crowns in. We can make the biggest implants, whatever we want to do. The muscles always win. Whatever we put into the mouth, it breaks if it's a heavy bruxism, and we don't have control of the function of the patient. But as I said, yeah. No, it's not live surgery. It was a recording I did of a patient a few weeks ago. So if there are any more questions, and thank you, Fadi, for your nice comment. I hope this covered some of the questions you had. I think it was quite a lot of information that was put into a short time, but I hope it was helpful, and at least that you saw my opinion on especially guided surgery and how you can utilize it in regards to facial aesthetics and planning of your implant cases. So I think that's it. Thank you and goodbye.
Thank you very much, Dr. Hatt, for sharing your lecture and your insightful information with us. We'd also like to thank DT Study Club for making this online course possible. And thank you, our wonderful audience, for your interest and participation. The CE quiz is now available online on the course page, and completing it will allow you to earn your ADA CERP CE credits. The recording will be posted online within the next 48 hours. You'll receive an email notification with the link to the recording. Further questions for Dr. Hatt may be submitted directly on the website, on the courses page, under the Ask the Expert tab. So please go ahead and submit your questions, and Dr. Hatt will be sure to get back to you as soon as possible. Please be sure to visit the DT Study Club educational platform, www.dtstudyclub.com, and keep an eye out for a growing schedule of online courses. Thank you again to all, take care, and goodbye.